Okay, it's 2 o'clock in Brazil, 1 p.m. in the US. Hello, everyone, and thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I'm glad to welcome and thank you all for being here today. My name is Aline Serfati, and I'm honored to co-host this session alongside Dr. Hilary Humans, who has been coordinating and moderating this series with me since 2021. Our guest speakers today are Drs. Adham Castro, Dr. Joseph Dobtsis, and Dr. Jenny Bencardino. Together, they will present a series of interesting cases highlighting the most relevant imaging findings and providing a literature review to enrich the discussion. At the end, we'll have a Q&A session. If you have any questions, at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. Hilary has also launched the OCAD channel on LinkedIn, so you can also check out amazing cases in the quizzes and stay updated about the sessions there. Okay, Hilary, please, you can now start to introduce the first.
Okay, it's great to see everybody on this Friday and to see how tan and relaxed Aline looks in warm Brazil. I have the honor of introducing my good friend, Joseph Dobtsis. He's the Assistant Director of Radiology at Harlem Hospital in New York City and Assistant Clinical Professor of Radiology at Columbia University. He did his medical school training at downstate in Brooklyn, New York, and he is fellowship trained both in musculoskeletal and neuroradiology. So since he's Assistant Director of Radiology at Harlem Hospital, he has informed me that Harlem Hospital is one of the most historic hospitals in the country and pioneered the training of African-American doctors and nurses in its early years. The radiology department provides critical radiology services to the underserved community of Harlem, New York. Joseph is also very interested in quality and safety and leads many performance improvement projects in his department. He's also very interested and involved in AI evaluation and its integration in radiology practice, and enjoys teaching and mentoring residents. I know that he's interested in 3D printing and its application to resident education. He's an avid sailor, and a couple of years ago, he chartered and skippered a catamaran around the British Virgin Islands, and apparently often sails in New York Harbor and Long Island Sound, which is particularly interesting to me. I want on a boat. Anyway, he has a deep appreciation of fine arts and theater, so he sounds like the perfect man. Okay, Joseph, share your screen. I think I made him blush. Okay, go ahead.
Thank you, Hilary, for such a wonderful introduction. I'm going to share my screen right now. So thank you, Hilary and Alina, for giving me an opportunity to present this very interesting entity that is, I don't think it's widely discussed in radiology, but something that is important to recognize. We published this case in the Journal American Pediatric Medical Association, and I'm really happy to present this to the musculoskeletal radiology community. So this is a case of a 29-year-old West African woman, and she presented with painful bilateral swollen fourth digits, worsening of pain and swelling, especially when wet. She had sought various treatments both in Africa and the United States. In Africa, she declined amputation as an option because the condition was tolerable using conventional therapy. She used methimethadone cream, which improved her symptoms, but then the symptoms return when she didn't use the cream, and she presented with open toe shoes to accommodate a large size of her digits. She didn't have any significant family history or medical history. And here I present to you the clinical images on the physical examination. You could see the dorsiflexed fourth digits bilaterally, abduction of the fifth digits. There's also axial rotation around the constricted base of the fourth digits bilaterally. Maceration and constriction fully encircles the fourth digit and was most prominent at the plantar and dorsal aspects of the digit at the level of the proximal phalangeal bases. You could see the swollen toes, and they were firm to palpation and did not display any erythema, discharge, or clinical signs of infection. The laboratory testing was done, and it was negative for scleroderma, no presence of anti-nuclear antibodies or evidence of other autoimmune diseases. So here we have an X-ray of the right foot that 2 years prior to the presentation. And so it shows a non-displaced pathologic fracture through the mid-diaphysis of the fourth proximal phalanx with associated soft tissue swelling of the distal fourth digit. The diaphysis of the fourth proximal phalanx is significantly narrowed and scalloped without significant periosteal reaction. Given these findings, it's reasonable to conclude that the fracture is pathologic because of the weakness of underlying bone. An important observation that the toe swelling extends just to the level of the fracture at the fourth proximal phalanx, where there appears to be soft tissue narrowing, an appearance that lends itself more to autoamputation than infection. This is X-rays 2 years later, the patient on current presentation. So on the left, we have the right foot X-ray. On the right, we have the left foot X-ray. So the right foot X-ray shows there is increased soft tissue swelling of the first toe, complete destruction of the diaphysis of the fourth proximal phalanx with a residual stump at the base and distal aspect of the fourth proximal phalanx, and the radiograph of the left foot on current presentations shows soft tissue swelling of the fourth toe, a narrowing and scalloping of the diaphysis of the fourth proximal phalanx, and pathologic fracture through the distal diaphysis of the fourth proximal phalanx. The patient had an MRI. There was concern for infection, or there was concern for tumor, so the patient, an MRI was ordered. And we have coronal and sagittal T1 weighted sequences here. We have a STIR sagittal sequence and a T1 fat suppressed post-contrast sagittal sequence. And on the T1 weighted images, you see this constricting band surrounding the proximal phalangeal, fourth proximal phalangeal diaphysis. That is low signal. On T1 weighted images, it's also low signal on the STIR sequences, but it enhances on the T1 fat suppressed contrast enhanced sequence. And of note, look how bulbous and how much edema there is in the distal fourth toe, distal to the area of constriction, and there's a lot of enhancement as well. So the diagnosis of dactylolysis spontanea Einhorn was made. And the patient, after being offered conservative treatment options, the patient elected to have toe surgically removed because previously really nothing conservative helped, and bilateral amputations were performed. This is an intraoperative picture that shows the area of constriction and a really swollen toe, and the toe was amputated. And then the more pathological specimens here shows proximal fourth phalanx, area of constriction here, and then after the soft tissue was removed, you could see how the distal aspect of the fourth proximal distal aspect of proximal phalanx was obliterated, and in the cross sections, you can see yellow fat is yellow. So as you get closer to the area of constriction, you have less fat and more fibrous tissue. So this is right at the area of constriction. So this is so now I'm going to talk a little bit about the entity Einhum, called Dactylolysis spontanea. The reason it's called Einhum is because in Yoruba West African language, the meaning of Einhum is to saw or to cut, and which describes the constricting nature of the disease. It's a progressive mutilating disorder of the digits. It's most common in people of sub-Saharan descent between the ages of 20 and 50, and is twice as commonly in male patients and involves bilateral toes in 75% of the cases. And prevalence is unclear. Some populations, but literature cites anywhere from 0.015% to 2% in endemic regions. The clinical progression of the disease come in 4 stages. Stage 1 is characterized by a hyperechotic lesion progressing to annular fissure surrounding the appendage and no swelling. Stage 2 demonstrates that bulbous enlargement of the appendage distal to the fissure and arterial narrowing coupled with bone resorption. Stage 3 shows the dangling toe, which is resorptive bony changes, narrowing and tapering of the phalanx, leading to fracture. Loss of distinction between cortical and medullary bone. And stage 4 is it's pain and autoamputation in the absence of bleeding. Quickly, I'm going to describe to you the treatment options for this. Stage 1 and 2 is early disease, mild to moderate disease. So there's options for conservative management, including creams, corticosteroids, calcium channel blockers, vitamin E, antioxidants. And then also you treat them with pain management, NSAIDs. Preventive measures include avoidance of trauma and footwear, and surgical interventions should also be considered, which include Z-plasty, which is release of the surgical band to prevent worsening of the symptoms. Stage 3 and 4 is more of an advanced disease, and stage disease, surgical management is usually the only options, and you can try to release the constriction, or you can go with the amputation of the toes. And obviously pain control and wound care are also very important. This is an interesting slide. So this is actually our patient that I presented to you. And these are microscopic images of immunohistochemical stained tissue specimen at the level of the constriction on gross section. And the slide on the left was stained for this glucose transporter 1. And the glucose transporter 1 is expressed, is used for confirmation of diagnostic infantile hemangioma, a condition theorized to result from in utero placement, placental disruption, and embolization of tissue from placenta into dermal and subcutaneous tissues of the fetus during development. So our patient stained positive for this transporters, and this gives another something to consider maybe as potential etiology of this abnormality, which is right now unknown. Now, Einhum is very important to make sure that there's no other inciting event that could cause the presentation, because there is another entity called pseudo-Einhum, which demonstrates physical examination and radiologic findings similar to those used to stage through idiopathic dactylolysis spontanea. And I'm just going to quickly show you a few cases of pseudo-Einhum to show you that you know how these look. So this is, for example, pseudo-Einhum in patients with Berger's disease, and you could see these bands, constriction bands in the toes, and on the X-ray you see there's areas of amputation and also areas of fracture through the phalanges. But this patient had history of smoking, presented with a lot of plain claudication, and the etiology of this was because of Berger's disease. So this is pseudo-Heim and Berger's disease. This is an example of pseudo-Einholm in leprosy, where you see here a constriction band. This is in the hands. Einholm usually presents in the feet, but this is just another example to be aware of that. So you could see here bands, and you see here also distraction of phalanges and fractures as well, and amputations. This is pseudo-Einholm in people with tuberous sclerosis. Patient with tuberous sclerosis, you see the band right here, and on the X-ray you see that the distal phalanx was destroyed. I'm not going to go through all of this, but I just wanted to bring to your attention that pseudo-Einholm is associated with many different disorders of keratinization, such as psoriasis, metabolic neurologic diseases, connective tissue disorders, such as rheumatoid arthritis, and other infectious and etiologies. And I just wanted to bring to you how many entities potentially could have caused this appearance. I would like to thank you for allowing me to present this case. I'm looking forward to your questions, and also feel free to email me if you have any questions. And these are my references. Thank you very much.
Thank you very much, Joseph. Beautiful case.
Thank you.
Now it's my great pleasure to introduce Dr. Adham do Amaral Castro. He graduated from Faculdade Evangélica de Medicina do Paraná and also holds a PhD from the same institution. He's a distinguished radiologist specializing in MSK imaging at the Hospital Israelita Albert Einstein and the Federal University of São Paulo. At the Hospital Israelita Albert Einstein, he leads the musculoskeletal radiology teaching program for radiology residents and fellows, and oversees research within the MSK radiology group. Additionally, he coordinates the institution's cutting-edge postgraduate course in MSK radiology. At the Federal University, Dr. Castro serves as the head of the MSK radiology sector. He's a professor of radiology at the undergraduate level, head of the Undergraduate Radiology Academy League, and supervisor of the Radiology Medical Residency Program. He's also an advisor for the university's stricto sensu postgraduate program, master's and doctorate in radiology. With a deep commitment to education and research, he actively contributes to knowledge dissemination and MSK radiology through lectures at major Brazilian radiology events. He's the author and co-author of numerous indexed scientific articles and book chapters in the field. Dr. Castro is a member of the São Paulo Society of Radiology, SPR, and the Brazilian College of Radiology, CBR, where he currently serves as one of the coordinators of the CBR Scientific Committee on Musculoskeletal Radiology. Please, Adham, take it away.
Thank you so much, Aline, for the introduction. It's an honor for me to be here today. I'll just share my screen, just a minute. Can you see my screen? I put in the presenter mode. Are you seeing my screen? Is it okay?
Yes, yes.
Oh, thank you. So again, thank you, Aline, for the presentation, and thank you for the invitation. It's an honor to be here. I will present one case today. So the case is for a male patient, 66 years old. He fell down the stairs while getting off the plane and suffered sprains to both of his ankles one day ago, and he had ankle pain and limited movement. So the patient underwent ER, bilateral radiograph in anterior posterior, Mortis, and lateral views. So we have here the anterior posterior views of the radiograph, and we can see is a marked soft tissue edema in the lateral perimalleolar region, notably in the right side, and no fracture or dislocation. So we have here the Mortis views, bilateral Mortis views, where you can see again the top soft tissue edema, no fracture and dislocation, and we can see a normal bone overlapping here in the tibia and fibula bilateral. Also a normal clear space, medial clear space, and again, no fracture or dislocation. And this is a lateral views where you can see the soft tissue edema, and again, no fracture or dislocation. This in the ER. So, following the investigation, the patient underwent MRI of both ankles. Starting with the right ankle MRI, here we have all the key images with the main finding that we'll show in the next. So here we have a complete tear of the ATFL. Then we can see here in the axial plane a complete tear. Also, we can see a partial tear of the CFL and also of the deep posterior tibial ligament. We can see this partial tear in those ligaments. And about the tibiofibular syndesmosis, it was preserved, so we can see the anterior inferior tibiofibular ligament. So here in the coronal plane, you can see the ligament, also in oblique plane and in the axial plane. We have a lot of soft tissue edema, but the ligaments were intact. So we have here in the side a low ankle sprain. Then the left ankle MRI. Here we have all the key images that I'll show next. So we have also here a complete tear of the ATFL. Also, we have here a partial tear of the CFL, as you can see here in these images. And about the tibiofibular syndesmosis. So we can see here in those images that we had a complete tear of the anterior inferior tibiofibular ligament. We can see here in the axial plane, the complete tear, also in the coronal plane, as you can see here, and in the oblique plane. Also, we can see a complete tear of the interosseous membrane. We can see here in the coronal plane, also here in the axial plane. So this patient, the left side, had a high ankle sprain. The joint space were normal, but we must remember that MRI is a static examination. So the patient has an ankle sprain, being in the left, a high left ankle sprain. But what about the left ankle stability? The space in the MRI examination was normal, but no widening of the syndesmosis. So he had no frank instability in the MRI examination. So, but the orthopedic surgeon requested a CT scan with stress maneuvers to investigate an isolated instability of the left distal tibiofibular syndesmosis. So, the CT scan with stress maneuvers, how does this exam is made? So the patients are put in a supine position, as you can see here in these images, and a cleric board connected to a pair of side strings of adjustable length supports the feet during examination. The patients hold the proximal ends of the strings and are provided with verbal instructions to pull strings and perform dorsiflexion at proper times through the room speaker. And it's important to note also that a band of firm elastic consistency keeps the knees bound during all the phases of the CT scan. So let's see the phases of the scan. The first phase that is the neutral phase. As we can see, one foot is parallel to the other and both feet are perpendicular to the long axis of the legs, and the knees are in extended position. The second phase is the first stress phase, and you can see the external rotation by placing the feet at 45 degrees using an angle meter and a vertical line as reference. Voice commands instruct the patient to maintain maximum dorsiflexion to the limit of tolerable pain during image acquisition. And then the second stress phase, the difference in the second stress phase that is also put a support pad that maintains the knees in a fixed position at 45 degrees. So it's important to note the support pad, also this band in the knees, because this is made to reduce influence from the knees and hips to the ankles. So back to the case, the patient underwent the CT scan with stress maneuvers. So you can see in the first phase, the neutral phase, an abscess of widening of the distal tibiofibular syndesmosis. We can see the anterior space, they are symmetric with the same measurement. And then the first stress phase, we can see an absence of widening of the distal tibiofibular syndesmosis. We can see here anterior syndesmosis with its measurements. And finally, the second stress phase, we can see a widening of the left distal tibiofibular syndesmosis. So it measured 4.6 millimeters, and before it was 2.3 millimeters. So this test was positive. It was a positive test for left distal tibiofibular syndesmotic instability. Then the orthopedic surgeon, with these results, proceeded to the surgery. So he fixed the syndesmosis with the tie rope system. So I brought this case to discuss about the distal tibiofibular syndesmotic instability. Acute ankle sprains are some of the most frequent musculoskeletal injuries. More than 75% of all acute ankle sprains are low sprains affecting the collateral lateral ligaments. The remaining 25% of acute ankle sprains involve the syndesmotic ligaments, so it's a high ankle sprain, and can also involve the deltoid ligament. High sprains can lead to prolonged disability, requiring longer recovery time and more complex treatments than low sprains. So about the relevant anatomy of the tibiofibular syndesmosis, it's a fibrous joint that links the tibia and fibula supported by 3 ligaments. So we have the anterior inferior tibiofibular ligaments, so we can see here in the A and B. Also, we had the interosseous ligament that we can see here in C and D, and the posterior inferior tibiofibular ligament that we can see here in E and F. About the biomechanics, we have in the syndesmotic injury a sternal rotation and or hyperdorsiflexion. Other ankle positions such as plantar flexion, supination, or pronation are also reported. Forced sternal rotations can widen the mortise and cause damage to the tibiofibular ligaments. Sternal rotation progressively tears the syndesmotic ligaments, starting with the anterior, then the interosseous, and finally the posterior, with varying injury degrees. So here you can see some schematic draws from A to C. You can see in A, intact ligaments in the systematic draws. In B, you can see the forced sternal rotation causing a tear of the anterior and interosseous ligaments. And in C, you can see a forced hyperdorsiflexion causing the tears of anterior and interosseous ligaments. And in sports practice, we can see here in D, in the football, a sternal rotation due to a direct hit to the lateral leg while down. In E, with this kick and lock on the ice and forces the foot to rotate externally and the skier's lower limb to rotate internally. In F, in soccer, we can see here a blow to the knee lateral aspect, and the foot remains locked on the turf in an externally rotated position while the body rotates in the opposite direction. About the classification, as a general treatment principle, unstable syndesmotic injuries are treated surgically and stable injuries are non-surgical. So we have the West Point grading system where you can see the grade 1 lesions are stable and the grade 3 lesions are frankly unstable. The grade 2 lesion can be stable or unstable, and is unstable is described as subtle, latent, or dynamic. We can see here in the table the West Point grading system. So when you have the grade 1, the ligament injured is anterior and this is stable and treatment is conservative. And about the grade 3, we have the lesion of anterior, interosseous, and posterior. It's frankly unstable and the treatment is surgical. What about the grade 2? We have 2A and 2B. So the 2A is stable and 2B is unstable. And this unstable lesion is described as subtle, latent, and dynamic, and the treatment is surgical. So the diagnosis of high ankle sprains, they have less edema and bruising than low ankle sprains. It has a painful palpation of the ligament, motion restriction with painful limitation in dorsiflexion, and no single clinical test is reliable for identifying syndesmotic injury with certainty, and additional imaging tests such as MRI are necessary. So about the diagnosis, the conventional radiograph usually is the initial assessment, and we have it have to be done the lateral, anterior, posterior, and mortise views. So here in A and B, we have a patient with no lesion. Here in the anterior posterior view, we can We can see a normal clear space, a normal overlapping of the bones, the tibia and the fibula. Also here in Mortise view, you can see the overlap of the bones and a normal clear space. And here in CND, you have a patient with a syndesmotic lesion. So in the anterior posterior view, we can see the overlap of the bones, but in the Mortise views, you can see there's no overlap of the bones, indicating that it's a frankly unstable lesion. The MRI has high diagnostic accuracy for syndesmotic ligament injuries, but it has limitations for diagnosing syndesmotic instability. It's a static exam and usually non-comparative to the uninjured contralateral side. Like all other static methods, MRI examinations can diagnose frank instability, but may miss the latent instability. About the conventional CT has a clear advantage in relation of radiographies because it eliminates bone overlapping, and the examination should always include the uninjured contralateral syndesmosis within the same field of view as a normality parameter. An unilateral examination may miss subtle instabilities, and frank instabilities can be quickly diagnosed. We have here an example of syndesmotic injury to the left side in a conventional CT compared in the same field of view of the right ankle. And now about the CT with stress maneuvers. The traditional imaging test may not provide a complete scenario concerning latent instability. So this new CT scan test involving stress maneuvers was developed by Rodrigues et al. And colleagues, and we have here some articles. This is an article describing the technique by Rodrigues and colleagues. So we have here radiologists and orthopedic surgeons, as you can see here. And this is a publication in the American Journal of Sports Medicine with the diagnostic accuracy of this method about the isolated syndesmotic instability. So the examination mimicked the primary mechanism of syndesmotic sprain, which involves external rotation and dorsiflexion. And about that publication that I cited, all diagnostic accuracy analyses were based on the difference between the measurements of the injured and uninjured ankles. It was made the rock curves that revealed ankle stress maneuvers with extended or flexed knees were more accurate in diagnosing syndesmotic instability than ankles in a neutral position. And the ideal cutoff point for the stress maneuvers was a diastasis difference of 1 millimeter between injured and uninjured syndesmosis in the rotational measurements, with the sensitivity and specificity equal to or greater than 83%. So this is particularly useful in diagnosing latent instability as the present case. So as take-home message, high ankle sprains are less frequent than low sprains, but can lead to prolonged disability, requiring longer recovery times and more complex treatments. The MRI is excellent, has an excellent accuracy for ligament injuries. The frank instability can be easily detected by static methods, but the subtle instability is difficult to diagnose and has repercussions on therapeutic decision, clinical or surgical. And I stress here the good accuracy of CT with stress maneuvers. This method has been well accepted by the orthopedic surgeons and has been widely used in our institute and in various services in São Paulo, Brazil. So thank you very much. I end my presentation here. It's my reference. Thank you very much.
Adam, that was very interesting. I have a bunch of questions for you later. You can find them in the chat. Okay, stop sharing your screen. Jenny, are you ready? While Jenny shares her screen, I have the pleasure of introducing my friend, Dr. Bencardino. She earned her medical degree in diagnostic radiology residency certification at Pontificia Universidad Javeriana, I butchered that, in Bogota, Colombia, in 1991 and 1996, respectively. She relocated to the U.S. and completed her residency training at Long Island Jewish Medical Center and fellowship training at NYU Langone Orthopedic Hospital. She started her academic career as an assistant professor of radiology at Harvard from 2000 to 2003 and was promoted to full professor at NYU School of Medicine in 2014. She's currently professor of radiology and vice chair of academic affairs at Montefiore Einstein, and also the chair of the promotions committee and faculty affairs liaison for the Department of Radiology. On a professional level, she's an active member of many U.S. and international radiology societies, in which she plays a central role. She's the author of 139 peer-reviewed articles and has been editor and guest editor of many journals and publications. She received the Reviewer of Distinction Award from Skeletal Radiology in 2010, 2011, and editor's recognition in radiology in 2014 and radiographics in 2023. She's the continuing co-consulting editor of MRI Clinics of North America since February 2024. Of note, she received the 2013 President's Medal from the ISS and 2023 Medal of the ISS as well. Education and mentorship are a major focus for Dr. Bencardino, and that's reflected in her receipt of the 2014 RSNA Honored Educator Award. I could go on, but I really cut that down significantly. I'm sorry if I butchered it. Okay, Jenny.
All right, so let's hope that Dr. Bencardino can share the screen now. Am I sharing the screen?
You're sharing the screen, but can you go to presenter mode?
Yes.
We're seeing the presenter notes. Perfect.
Okay, excellent. So
Okay.
I passed this test. All right, so I'm really glad to be here. I consider Dr. Humans and also Dr. Safati very close friends, and we'll share a case in the next few minutes. So the clinical history is a professional basketball player. He's 20 years old and sustained an inversion trauma during an NBA game with sudden onset of pain along the medial malleolus. So this is medial ankle pain following trauma during basketball play. The on-site radiographs at the sports arena revealed no acute fractures, and on physical exam, he had very exquisite tenderness over the medial ankle, and there was swelling and also popping sensation in that location. So these are the coronal and axial fluid-sensitive T2-weighted fat-suppressed images obtained in our patient. And what it's most important or catches our eye right away is that the periosteal layer overlying the medial malleolus is stripped off, and it's stripped off along with the attachment of the flexor retinaculum. And we can see that this injury has a sleeve pattern where the flexor retinaculum is continuous with the periosteum, and then is also continuous with the superficial components of the deltoid ligament. So the deltoid ligament complex has a superficial component origin at the anterior colliculus of the medial malleolus, and all this complex is detached from the bone. That has created this reactive marrow edema in the medial malleolus. And it's very important to note that the posterior tibial tendon is sitting nicely within the medial retromalleolar groove. In addition, we see some changes in the lateral ankle, which we'll address a little later. Here we are a little further down, and I think this is a really nice depiction of that detachment of the superficial origin of the deltoid from the medial malleolus, which is happening along with the PTT, and again, along with the flexor retinaculum, and the PTT again sits nicely in place. There is some edema also of the deep fibers of the deltoid. So let's review the anatomy of the flexor retinaculum. This is a structure, it's an aponeurotic structure located medially enclosing the tarsal tunnel. And that's really, really important. We have the posterior ankle divided by this flexor retinaculum into a deep flexor component inside the retinaculum and a superficial extraretinacular compartment. It is triangular in shape, and we're going to see that better when we see drawings depicting it in the sagittal plane. It goes from the medial malleolus to the posterior-superior aspect of the calcaneus, and the base of the flexor retinaculum corresponds to the superior border of the abductor hallucis muscle, continues with the plantar aponeurosis at that attachment into the calcaneus. Typically, the thickness of the retinaculum is very, very thin, so it's like pencil thin up to 1 millimeter. And here we have the drawing showing the attachment, and we have the flexor compartment, posterior tibialis, flexor digitorum, and flexor hallucis with the posterior tibial neurovascular bundle. That's the normal configuration. When we have flexor retinacular injuries, we can have 3 types. Type 1, the retinaculum strip off from the bone, but is not completely detached. Type 2 is when there is complete detachment, avulsion of the retinaculum from the medial malleolar insertion. And then type 3 is when the posterior tibial tendon does not sit nicely anymore within the medial retromalleolar groove and exits the groove and is dislocated or sublocks under the retinaculum. These are the drawings in the sagittal plane showing the extension of the medial of the flexor retinaculum from the medial malleolus to the calcaneus. And this helps us to see that oblique orientation and its relation with the origin of the extensor digitorum brevis and the plantar fascia lower down. And here in the coronal plane or axial oblique coronal plane, we see a flexor retinaculum again with the flexor tendons. Now let's move on to the lateral side. So we have edema clearly overlying the lateral malleolus. And then here the players are going to be the superior peroneal retinaculum and the peroneal tendons. So what I want to check is where is that superior peroneal retinaculum inserting? And so far, it seems to be inserting nicely into this triangular shaped structure that is edematous, but seems to be in place, called the fibrocartilaginous ridge. So the fibula has a ridge coming out of it laterally that is made of fibrocartilaginous tissue, and that's where the superior retinaculum attaches to. And the SPR is going to be roofing the peroneal tendons, which are sitting nicely within the peroneal tunnel here as well. So we have the peroneus brevis anteriorly, the peroneus longus posteriorly, and at this level, the peroneal tendon sheath is common, so we have fluid surrounding both tendons in that location. Going further down, we see the same triangular structure arising from the lateral margin of the lateral retromalleolar groove, and that corresponds to the fibrocartilaginous ridge. The superior peroneal retinaculum is edematous, but is attaching into the ridge, perhaps with a little bit of a stripping. So this arrow here is showing maybe minimal stripping, but there is no detachment or disruption of the retinacular fibers. So the peroneal tendons, as I mentioned, but travel posterior, the peroneus longus travels posterior to the peroneus brevis. So we are seeing that here in this drawing. And they are sharing a common tendon sheath, which splits at the level of the peroneal trochlea in the lateral calcaneal wall into individual sheaths. So sometimes you can see fluid within the peroneus brevis or the peroneus longus tendon sheath, just specifically if the injury or the issue is below the level where the tendon sheath splits. Now, the superior peroneal retinaculum is the primary restraint that prevents subluxation or dislocation of the peroneal tendons out of the groove. It is important to note that 10% of people do not have a groove. They actually have a convex posterior lateral malleolar margin, which contributes to instability, among other things, which we can count accessory muscles that can live here, particularly the peroneus quartus, or low-lying muscle, accessory muscle bellies of the peroneus brevis, which can also cause overcrowding within the tunnel and therefore a tendency for the tendons to try to go out of the groove. Now, superior peroneal retinaculum is also pretty thin. It's been described with a range up to 2.6 millimeters, but the average is 1 millimeter. And it's contiguous with the superficial and deep aponeurosis of the posterior segment of the distal leg. So if you start following the aponeurosis from the leg down, you're going to see that there is continuity of the fibers there. And it attaches, as I mentioned before, to the lateral border of the retromalleolar groove. Now, there are many classifications for superior peroneal retinacular injuries. I like Adham's classification. I kind of remember it better than the others available in the literature. So I'm going to go with that and describe the classification here. So we have the fibrocartilaginous ridge, the SPR. This is the normal anatomy, both peroneus brevis, peroneus longus, anterior, posterior located. And then we have on type 1 a strip off superior peroneal retinaculum. So it's detached from the bone. In the type 2 is actually tore off at the site of insertion into the lateral margin of the retromalleolar groove. And then in type 3, there is a little piece of bone, which when we see it, we get all excited. So that would be an avulsion fracture at the insertion into the fibula. And then we can have a type 4 where the tear is through the mid-substance or mid-portion of the retinaculum. That's not very common. And here we have MR depiction of a normal superior peroneal retinaculum. Is showing the confluence of these superficial and deep aponeurotic fibers into the retinaculum along with the cadaveric slice point through that same region. All right, so our patient has a type 1 Adham retinacular injury, has that mild stripping of the periosteum. So what are we looking for in the setting of superior peroneal retinacular injuries and peroneal tendon instability? So we want to check on axial images. We're going to look for the presence of a superior peroneal retinacular pouch, the presence of effusion within the tendon sheaths of the peroneal tendons. There can be also peroneal tendon tears associated with it. Whether or not there is a convex fibular groove, I always make a point to put that in my report. Look for that avulsion fracture of the distal fibula. It is even more exciting to see it on X-rays, so we know where it attaches to, and we can look for it on the frontal or oblique views of the ankle. And then these injuries are very often associated with lateral collateral injuries. This is a massive injury to the SPR. We see that there is detachment of the retinaculum and the tendons are spilling out of the retromalleolar groove under the torn retinaculum. And was a very subtle case, Brazilian marathon runner. We had the patient dorsiflex within the gantry, and you can see this is plantar flexion, neutral plantar flexion is how we image routinely the ankle. We just let the foot rest nicely, and that's 20 to 30 degrees of plantar flexion. And here we ask the patient to dorsiflex, and we can see how the peroneal tendons are trying to, spill out from the retromalleolar groove because the SPR was not stable, was lax. So here just a review of the retinacular injuries. We already have that. And we can go back to our case and put everything together. So we have a type 2 flexor retinacular injury here where the flexor retinaculum is completely detached from the bone and is in continuity with the periosteum and also with the origin of the deltoid. And on the lateral side, we just have a type 1 retinacular injury. This concomitant appearance or concomitant occurrence of medial and lateral retinacular injuries is not that uncommon. So just to summarize here, this is a combined grade 2 flexor retinacular injury with a grade 1 superior peroneal retinacular injury. Pay attention when we have the flexor retinacular injury at the medial malleolus. It is often associated with tears of the superior deltoid ligament, and that concomitant occurrence is up to 37%. And then we have in this patient a stripping of the SPR and associated peroneal tendon sheath effusion. I warn you not to say tenosynovitis because this is not an inflammatory process of the sheath. This is just reactive crying of the tendon sheath in the setting of acute trauma. And that's all what I wanted to show today. Thank you.
I'm going to jump in because we still have Jenny. I have one question for you. When you see the stripping of the flexor retinaculum or of the supraperoneal retinaculum on MRI, but the tendons are located, do you recommend ultrasound with stress maneuvers?
I always do. And in these patients, very often we don't see them in the acute setting. So they come back because they have chronic pain in the lateral ankle and they feel some popping sensation, something is going on there. You do the MRI and maybe all what you see is some thickening of the retinaculum, some wispy, scarring of the adjacent fat. So that is an indication for that patient to come and have dynamic targeted ultrasound of the peroneal tendons with maneuvers, basically dorsiflexion, plantar flexion to see the instability of the tendons. Yeah.
Great, that's very helpful. Thanks.
Yeah.
I have a question for Adham.
Yes.
Okay.
I see here
If it's in the chat, I'm reading it. High ankle sprains are often underestimated in terms of their long-term impact. While in many cases resolve with conservative treatment, some patients develop persistent pain, instability, or even post-traumatic arthritis over time. Given the complexity of syndesmotic injuries and their potential long-term consequences, advanced imaging plays a crucial role in patient management. In case of chronic high ankle sprains, how can CT and MRI be used to assess long-term complications, such as syndesmotic instability or post-traumatic arthritis?
Okay, thank you, Aline, for the question. So the paper was published with like 3 weeks acute cases. But in the practice, this is not answered question in the literature, but in the practice, we have made some of these examinations in chronic patients, and we have seen that the instability remains. And also the MRI, we can see like the residual fibrotic tissue causing like soft tissue impact, and very disability for sports practice, and it's really a disability in the life of those patients. So yes, it's really important, and we keep seeing those instabilities. It's not published yet, but we are still seeing those instabilities in chronic patients in the CT with stress maneuvers. There's one more question.
I have a question for you.
Here. First, the advantage.
To read it for you, I think.
Okay.
So I asked a couple of questions. One was, do you think there's a diagnostic advantage of CT stress imaging compared to radiographic stress images?
So the stress radiography, Dr. Rodriguez thought about doing the stress radiography instead of the CT, but the stress radiography is difficult to do. I think it's more difficult to do, to pattern and to compare with the contralateral. So we suppose that the CT stress would be superior. That's why we choose the CT with stress.
And then I just wondered if you've tried to use this construct with MRI.
Well, it's a great idea, but we have some additional difficulties because first we need a device that is compatible with the magnetic camp and also that fits inside the coil. And then the ideal exam is like comparative, so we would have to maximize the FOV and we would lose resolution for the diagnosis of the ligaments. But it's
think about that, the comparison. Yeah. Okay, very interesting. Something to work out. So, Joseph, there were some questions. Elena.
As for Joseph, what specific imaging features on X-ray or MRI can help predict the progression of Adham, and particularly in terms of joint involvement or potential deformities?
Thank you for the question. Unfortunately, the progression itself is very unpredictable. There's not a lot of literature to say how long, what the progression is. There are stages, so this disease process goes to several stages, and the imaging characteristics can guide treatment. So if for example, the bone is just scalloped, narrowed, you potentially the patient could get a surgery to release the constriction. But if it's already, the bone is already destroyed, then most likely the patient will need an amputation. And also, so earlier recognition of the entity could help guide treatment and maybe slow down the progression.
My question, I mean, I think the main impediment to diagnosis is a lack of familiarity with the entity. So I believe that the radiographs are largely diagnostic, but from a perspective of distinguishing it from pseudo-Einholm, just in terms of the anatomic location, right? I think that's largely helps confirm the diagnosis. Is it almost always at the fifth or fourth toe? Does it ever occur anywhere else? Is it always at the proximal phalanges?
So based on the studies that I looked at, 95% of it occurs at the fifth toe and proximal phalanx. So that's kind of, they looked at like 100 patients. There was a study that looked at 6,000 patients, but only 100 of them actually had Einholm. So kind of, and then they found that 95% of these patients, it's the proximal phalanx. So yeah, so that's kind of the location for it. And in terms of whether imaging, MRI imaging helps, I think your point that this is not well recognized, and because people are not aware of this condition, a lot of times there is a question, especially in late phase, could there be a sarcoma? Could there be infection? Something destroying the bone? They don't pay attention to the bulbous appearance of the soft tissue swelling, and then tapering right where the bone is destroyed. And then they start questioning infection, sarcoma, something like that. And then you do get an MRI, And then you could see that there's a constriction and edema distal to the constriction. Also, if you have good clinical history, podiatrists or orthopedic surgeons can also recognize it. And they might decide not to do the MRI because they know the diagnosis. So that is also.
There's
like-
last question in the chat from Dr. Gaseb. I would ask about the case of syndesmosis injuries, why you did not consider transverse tibiofibular ligament. I think it's for Adham.
Thank you, Dr. Lisa. Well, it's very difficult to analyze the transverse ligament. Sometimes we can see well, others we can't see well. So it's difficult to isolate it, right? And in the paper, we have considered the grade 2B and 2A for the West Point system. So it's the anterior and interosseous ligament, and that's why.
Okay, thank you very much. It's 3 p.m. in Brazil, 2 p.m. in the US. Thank you all for joining us today. Our next session is scheduled for April 11, and it will be a mixed case presentation again. Mark your calendars. We'll see you then. Bye-bye.